on to our last session. We have a panel discussion on HCC. I'd like to invite Dr. Jeebak Bhattacharya, radiation oncologist, Apollo Kolkata, Dr. Kingshuk Das sir, gastroenterologist, to chair the session. I'll also ask Dr. Manoj Shah to join the chair as a chairperson as well as a panelist. Manoj Shah sir is an intervention radiologist working at Apollo Kolkata. May I request the chairperson to introduce our moderator as well as the panelist?
Yeah, before we go there, Animesh, it's a fantastic session. Being a gastroenterologist, medical, I've learned a lot from the post-lunch session. And in fact, what Dr. Ankur was saying, I think in this session, half of the things are more or less covered by both the debaters, Dr. Ganesh and Dr. Nayanand. There's a huge interaction, so we learned a lot from them. As far as if I am supposed to introduce Dr. Ankur, everyone in the audience and viewers, everyone knows him, Dr. Ankur Bahl, who started his journey from MAMC, as I remember, and he went to EMS, and from there now he is the Director of Medical Oncology, Fortis Memorial Research Institute, Gurugram. And I think, Jeebak, you introduce the panelist.
Good evening, everyone. So I will be introducing the panelist, Dr. Venkata Krishna Pilaka Reddy, who is a radiation oncologist from Mahatma Gandhi Cancer Hospital, Visakhapatnam. Dr. Tanu Chawla, Tata Medical Center, Kolkata. Dr. Amit Kumar, Jayaprabha Medanta Super Specialty Hospital, Patna. Dr. Manoj Shah, he is with us. He's an intervention radiologist with from Apollo Hospital. Dr. Ritika Harjani Hinduja from PD Hinduja National Hospital. She is a radiation oncologist. And Dr. Shruti Banerjee, GI and HP hepatobiliary surgeon from Tata Medical Center, Kolkata. And Dr. Ishtiaq Rahim, radiation oncologist from Square Hospital, Bangladesh. So to Dr. Ankur Bahl for the...
Yeah, thank you, chairpersons, and thank you, organizers, for giving me this opportunity. And can I present my slides? Yes. Yeah. So we have heard the previous speakers, the local therapy, the intervention radiologist, the radiation oncologist, but I believe that hepatocellular cancer has changed so much that now, as a medical oncologist, as an oncologist, I have so many options in child POG A and so many options in early child POG B that now I have to choose between therapies. Now I have to choose which therapy gives the best survival. And out of very costly immuno and bevacizumab combination, the IMBRAE 150, the atezobev, we have very cheap drug, which is lenvatinib, and we've been using sorafenib long. And we have seen the transition that in last 5-6 years, the sorafenib is actually out of the practice. So lenvatinib is the main drug. And now lenvatinib in combination with IO or IO in combination with bevacizumab has suddenly changed the scenario. And now we see what we call is the overall survival. Now we call it disease control rate. We see the response rates in hepatocellular, which 12 years or 10 years or even 8 years back was declared as a death sentence in a patient with chronic liver disease. So next slide. So hepatocellular carcinoma, we know still in India, hepatitis B, hepatitis C, and lately coming up is the alcoholic liver disease, the NASH related disease, which is coming up. And now even we have a literature published in Nature, which differentiates these two diseases, hepatitis B and hepatitis C related chronic liver disease giving rise to HCC, and alcoholic liver disease or a NASH related CLD giving rise to HCC has a different approach. And this is what I'm going to emphasize in next half an hour, that in which patient to use which drug and how to choose that drug if all three sorafenib, lenvatinib, and atezobev are applicable. Next slide. So I would straight away go to the senior most Dr. Reddy, the radiation oncologist, and Dr. Kanu Charan Patro, radiation oncologist. So do you see the incidence of HCC going up, and do you see that the mortality in HCC going down? This graph clearly states that the blue graph is the incidence is rising, and suddenly the mortality between the incidence diagnosed case and the death is there's a gap. So how do you explain this gap, Dr. Reddy and Dr. Patro?
So sorry, but Dr. Kanucharan is trying to log in, and Dr. Venkata will log in too.
Okay, so
Yes,
so Ritika is there. Ritika Hinduja is there.
Yes, I'm there.
Yes, Dr. Ritika. So how do you explain this graph? So the blue graph is rising and the gray graph is going down. So we are seeing the decrease in mortality of HCC. How do you explain this phenomenon?
I think, as you mentioned, that with the newer systemic agents, I think the mortality, which, as you mentioned, the death sentence is now, they have some more survival to them, and that is why I think probably it is declining, the mortality. And plus, as compared to before, where we in India at least we considered liver cancers to present especially in the very late stage. Now we do see some early tumors which can be treated with local therapies. So I think the incidence of early tumor detection and with better systemic therapies for advanced stages, I think that's the reason for the gap.
Yes, yes, you rightly said, Dr. Ritika, that the surveillance, our gastroenterologists and the hepatologists are putting this disease on surveillance. In chronic liver disease, there are many institutes who are getting a routine ultrasound, AFP, and now they are moving towards a triple phase CT scan very routinely to pick up those lesions and early lesions. And we medical oncologists and we clinical oncologists will come late, but we have heard a beautiful talk from Dr. Ganeshan, an intervention radiologist, that these local therapies, the thermoablative therapies, the TACE, the TARE, the combination of TACE, TARE, the combination of SBRT and TARE, giving rise to that localized liver cancer, which can be treated early. And then when everything fails, when it becomes unresectable or metastatic, then we medical oncologists also have further options in first line, second line, and we have data on second line also. So we have all seen that our patients are moving beyond first line, second line. And this all scenario, this all combination of surveillance, localized disease, locally advanced disease, bridging that transplantation gap and further giving rise to systemic therapy has increased our survival. So Dr. Sudeep Banerjee, are you there?
yes, I'm there.
So Dr.
Can you hear
Banerjee,
me?
so yes, so how is your practice changing? How your liver cancer patients are actually living longer, and how do you decide that resectable, unresectable, gross vascular invasion, extrahepatic vascular involvement in your practice?
Yeah, so first of all, we're a referral center, so we tend to see both little early as well as advanced disease. And our workup, we routinely do MR liver because we know that MR liver picks up some more disease in the contralateral liver, the future liver remnant, or maybe a satellite lesion or something like that with a big tumor. And also we do a chest CT scan. We don't do a bone scan unless the AFP is very high. There are data from Korea saying that if you do a proper CT scan with the thorax and abdomen, bone scan is usually not necessary. Now, what we have the treatment of HCC you see at present, if you talk about cure, there are only two treatments which can lead to cure. There are other treatments evolving. One is the resection, another is the transplant. Even if you see the smaller lesions, if you see there are recent data from Korea, if you see even if the smaller lesion, if you compare ablation with resection, the cancer specific death with resection is better. So cancer specific death is low with resection than the RFA, but definitely there are a lot of other things we need to consider. But now what we are doing now, whether first of all we see that whether this is upfront resectable or not, or upfront transplantable. If it is not, then we see that whether anything we can do to downgrade it to a resectable stage. For example, like adding some treatment like a TARE or a TACE or a combination of TARE or a microwave ablation, or some setting giving radiation to the portal vein. If there is a thrombus, maybe a V3, V4 type, mainly V3 type thrombus, So with the advent of multimodality treatment, few patients we are giving some upfront treatment and then resecting and hoping that the results are better. Having said so, also like over last many years in our centers also, the liver resection for HCC, the mortality is now close to 0%. So you see the data, it is evolving slowly. When we are training, it is around 5 to 10%, 20 years back around 15 to 20%. But now for liver resection, properly selected patient, the mortality has come down to less than around 0 to 2% maximum in a properly selected patient. So the combination of therapy is definitely coming up when the patients are upfront, not resectable.
Very well said, sir. And you have beautifully summarized that our radiologists have made our life easy. Our intervention radiologists, the multiple local therapies in the form of thermoablative, RFA, microwave, and the combination of multiple TACE SBRT or SBRT TARE has given that edge to the surgeons where they can resect, transplant, and you rightly said that even the branch portal vein should not be considered as a contraindication to liver transplant later. And very rightly said that surgeons have given that survival advantage where these resections and a bridge to the resection or bridge to the transplant is the way forward. So I here bring a case which very commonly seen in our Indian practice, and anybody in our panelist who can describe this PET CT scan so that I can take this case forward.
So may I take it?
Yes, sir, sure.
So this looks like if you see not the FDG scan, but the normal scan, this looks like a CLD, the irregular liver surface. And you can see a large lesion in the liver, as well as most likely a large lymph node in the porta or in somewhere. But I don't know whether HCC, such a avid HCC lesion, HCC usually low avidity, low FDG avid, but is an avid lesion in a chronic liver disease with a large node, what I feel.
Yeah, so this was this patient is no more. So this was a 35-year-old gentleman, hepatitis B related CLD, presented to oncology department with a huge liver lesion, and what looks like to a lymph node was a main portal vein thrombus sitting very separate from the liver lesion. And it was an unresectable disease. This patient is not a transplant candidate. So, and his child book B evaluation was score of 7, B7. So Dr. Amit Kumar, you are there as a medical oncologist here, Dr. Amit?
Yes, sir. Sure.
So Dr. Amit is here and Dr. Manas Saha is here, and we have radiation oncologist. Whose baby is this patient? How to proceed? The patient is B7, 35-year-old hepatitis B related CLD, big portal vein thrombus with a score of child book B7 and a good performance status of 1, I would say, walking to my OPD.
So the disease volume and the size, which say is too high, and the portal vein involvement is too good. Might be it's the systemic therapy from my end will be the preferred first choice rather than going for SBRT.
What is bilirubin and
so it was child book B7. So there were two things abnormal. Bilirubin was normal. There was no ascites. INR was normal. Albumin was slightly low, 3.2 and less than 3.5, and there was no encephalopathy. The score becomes B7 or an early child book B, not A. This is not A.
So when he is walking to your clinic, yes, I think it's if we can treat, okay. So then this portal vein, I would like to go for SBRT for the portal vein, and if it recanalizes, then go for TARE if they can afford.
Yes. So rightly
so
said.
But first is SBRT. So
yes.
We'll leave aside the previous discussion, whatever it is. So I think SBRT have a great role to play, especially if it is a portal vein thrombosis.
Yes. So it was
for
a
tumor, for big tumor, I definitely like to have my reservation, because SBRT I can use any other time later on if required. And if we have other therapies like local ablative or TACE or anything, I would like to use that first. In this case, a lot of radiation will take, this SBRT will take a lot of thing for this portal vein thrombus. And portal vein thrombus, as it is said, that it will decide the fate. So first treat the portal vein and then go for the next line.
Yes. So we have an intervention radiologist on board as well. So Dr. Saha.
Yep, I am.
Yes. So Dr. Saha is saying that we would like to go for an SBRT, but sir, why not tear in this patient? Main
Tear.
portal vein is not a contraindication for tear. With tear,
Yep.
we can easily do, and patient affords it.
Yeah, really. But it is seen that tear, as such, even with tear, the portal vein thrombosis results are not great. If it's a tumor thrombus, it always better responds to SBRT than tear.
Yeah. So
and if you see now, they are doing huge numbers in Medanta, where they are seeing the great results, and they are doing it in combination, tear plus SBRT.
Next slide, right? Please.
And then medical therapy.
Yeah. So we have discussed, so the Dr. Saha and I believe my rest of the panelists also agrees that this patient should go for an SBRT. The response rate in literature, there are many studies which I will come in next slide. The chances that this SBRT dissolve this portal vein is as high as 35 to 45%. And if this portal vein get dissolved and responds, we have seen in our clinical practice that the child pug also increases, and it makes it eligible for another local therapy, which could be tear, and later on systemic therapy, and we can give. Coming on to a different scenario, an alcoholic liver disease, HPV, HCV negative, monitored by a gastroenterologist, you can say regularly or irregularly, abstaining from alcohol, alpha fetoprotein of 1900 microgram, and there are two liver lesions, one in segment 8 and one in segment 3, 4 into 3 centimeter and 2 into 2 centimeter. My question is very straightforward to Dr. Banerjee. Is this operable? Would you like to operate first? You would like to give a local therapy first? And what decides what? Is this Milan? Is this beyond Milan? Or it is
it's a bit of beyond Milan, but I think this patient, 71-year-old, with a little bit of outside criteria for transplant as well, but with some sort of an AFP also quite high, 1900. But this patient, maybe a combination of, if the liver function is preserved, maybe a combination of space with a microwave can be and observed for some time, and then can become a transplant candidate, not a resection candidate because of CLD.
Yes. So Dr. Tanuj, if you can chip in and tell us that as a GI oncologist, as a GI and person who's looking at this HCC very quite often, what are those poor prognostic factors upfront which stops a surgeon to operate this operable tumor? If there are two tumors, patient is in child pug A, but what are those poor prognostic factors in a patient which should be considered on day one to decide these local therapies?
You mean the surgery that you're asking for?
So I'm just asking a general question. What are those poor prognostic hepatocellular cancer as a surgeon, as a intervention radiologist, or as a medical oncologist? What should we see upfront? What are those pathological factors? What are those secretory factors which decide, as Dr. Banerjee clearly was like saying that is alpha fetoprotein is high. So what is that volume of HCC in your knowledge? What is that amount of alpha fetoprotein which says that no surgery, this patient should go for a local therapy?
I would say not only biochemical marker, we have to look at the patient as a whole. What is the current performance status of the patient? Good thing is that he is viral negative. The bad things which, in addition to the performance status, we also have to look at the where the lesion is, whether it is close to the portal vein, how far is it from there. That's another criteria what surgeons look into. Again, number of lesions, but here I can see there are two lesions, but one is 4 centimeter, which is little more than what the surgeon's criteria, the theoretical criteria mentioned in the books. or the articles.
Next.
Second thing is the AFP, Dr. Sudeep has already mentioned about it. And there is an autoimmune liver disease, which is it positive marker? The markers are negative. So again, autoimmune liver disease, if it's there, then again, that's again a negative prognostic marker. That's what
So I
can
think,
think
yes,
of.
you rightly said performance status of the patient, child POC, the Barcelona staging, how close is and what is that extra hepatic vascular involvement, the baseline alpha fetoprotein. But yes, the world is also moving towards. So we used to say that biopsy is not that essential, but in this immunotherapy and in the targeted era, which is coming, the biopsy, the liver biopsy, the hepatocellular biopsy is very important. There are various prognostic criteria: lymphocytic rich, lymphocytic depleted, beta catenin positive, beta catenin negative, and there are various biomarkers, MSI, PDL1, tumor mutational burdens. So these biomarkers actually decide the way forward, which patient will be treated, should be treated with lenvatinib, and which patient should be further treated with IO or bevacizumab. So I'm talking about systemic treatment, but yes, you rightly said there are prognostic criteria: alpha fetoprotein size, the volume of HCC, performance status, the Barcelona staging, the child POC status, they are equally important. Next slide, please. So we have discussed, with Dr. Banerjee has said, how do we evaluate resectability, and in unresectable patient, what are the most appropriate loco-regional therapy? I think I should move beyond. There's lots to discuss. Next slide. So historically, we all have seen, and Dr. Amit and Dr. Ritika and other medical oncologists are there. Ritika is a radiation oncologist. So we have seen that historical development of this HCC. We used to have sorafenib in our early days, 2007 to 2000, I would say 14, 15, when there was sorafenib. We were not able to give appropriate doses of sorafenib. Not many patients were tolerating beyond 400 BD or 400 OD. We have to de-escalate the dose. We have to decrease the dose because of hand-foot fatigue. Then came in our life was lenvatinib. So Dr. Amit, I want you to give 2 to 3 minutes on this lenvatinib, how this drug has made your life easy post sorafenib days. Dr. Amit.
Yeah, surely the side effect profile and efficacy wise, both lenvatinib is easier. The side effect with sorafenib, the hand-foot syndrome, is the most different, and hardly few patients tolerate 400 BD that cases. For lenvatinib, the weight-based dosing, whether 8 milligram or 12 milligram based on the weight, it is an easier drug to tolerate, and especially in the SCC patients somehow tolerate lenvatinib much better as compared to other malignancies, what we have seen. And though there are few conditions in which we are not using lenvatinib is not as effective, if there is a portal vein thrombosis or an arterial thrombosis is there, in those patients, lenvatinib is not a good choice. For sorafenib, it is similarly, if there is a hepatitis C infection, it is still a drug of choice, we'll say, if a patient is having SCC4 after that. So, or if there is an extra hepatic disease, lenvatinib is a good option in those cases, sorafenib is not, I will say. So, and the side effect, hypertension is the most common side effect we say with lenvatinib, which we is having other than the dry skin or diarrhea or other things. But still, it is a very easily tolerable drug, and we are so sorafenib is mostly out, I will say.
So where, yes, I was going to ask this very blunt question: when have you last written sorafenib in hepatocellular cancer?
So in recent years, no.
No. So in recent years, with all due respect to SHARP trial, sorafenib is out, lenvatinib is in, and if I go further to the NCCN guidelines, may I go next to the next slide? Next slide, please. Next slide. Please move on. Next slide. Next slide. Yes. So Amit, this is NCCN 2022. Atezo-bev is category 1. And in other recommended options, sorafenib and lenvatinib is also category 1. But somehow NCCN has given the preferred regimen tag to atezo-bev. However, sorafenib and lenvatinib are still in child PUG A category 1. And if I go to the next slide, 1 year back, the NCCNs, there was in preferred regime, all these 3 drugs are there: sorafenib, lenvatinib, and atezobev. So suddenly in 1 year, atezobev has become the preferred choice. However, sorafenib, lenvatinib are still holding the category 1. So somehow the clinicians, the pharmacology industry, and hepatologists, why there is inclination towards this atezobev? Amit, can you please explain what is that? I have given atezo, you have given atezo. Is it that effective drug in our Indian patients? Are all patients responding, and this NCCN preference holds true or not in your mind?
So it's not like that. Basically, atezobev, we have to do the pulmonary endoscopy, rule out esophageal varices, chances of bleeding. Only if the patient is, so a definite subgroup of patient in which we are going to consider atezo and bev. And in Indian population, hardly patients go for more than 6 cycles. I will say most patients are going to progress in 7 to 8 months. Maximum, what I have seen, maximum number of patients. So for Indian scenario, I think so it's all equivalent. Might be the lenvatinib and sorafenib. It's the thing that it's a new drug and we have got a second line options much better. So for immunotherapy, it is said that as early you use, it's the better response rather than in the second line when we have got a less response.
So Dr. Tanuj, your views on that? I want to, Amit has explained a bit of it. Dr. Tanuj, if you can throw some light beyond what Dr. Amit has said.
Yeah, NCCN guidelines, we all know how they work. It's difficult to say. We are in a different setup. We are in a different region of the world. Definitely, the patients I have given atezobev, they have done really well. Lenvatinib works for a few months, and then, as the trial has said, 2-3 months, and that's all. The side effect profile is good, but most of the patients are on lenvatinib at our center. Cost is a big issue for atezobev. It's a wonderful combination, but unfortunately, we do not have our patients taking up, a lot of patients taking up this option. Definitely, it is much better than lenvatinib and sorafenib. If the patients can take it, I would go for that.
Yes. So another factor which is clearly come up is the cost factor. That cost the cost of lenvatinib is actually nothing in view when it comes to atezobev, and we have so many generic molecules giving us lenvatinib, and easily tolerable, pocket friendly, not even an admission required, and can be monitored in OPD. But Dr. Tanuj, we have hepatitis B, we have hepatitis C related CLD, we have NASH, and we have alcoholic liver disease. Patient says, I can spend as much as my oncologist want. I want the best result. You have lenvatinib experience, you have atezobev experience. Will you differentiate according to the etiology of CLD? It comes in your mind, or it all depends upon the pocket, or it all depends upon any contraindication to atezobev or lenvatinib? Dr. Tanuj.
Definitely, contraindications are there with atezobev. Uncontrolled.
I'm saying, sir, no contraindication. Both the patients can take lenvatinib and atezobev. Cost is not a factor. Is etiology a factor in deciding one of these drugs?
If the patient is treated with hepatitis B and C, I would go for atezobev.
Yes. Yes. So, and what is in your mind going in favor of atezobev?
The response trial, I am Brave 150.
Yes. Amit, you want to argue on this, or you any comments on Dr. Tanuj Chawla's statement?
No, it's okay. If the disease is controlled, both hepatitis B and C, it has to be controlled before starting atezobev. The reactivation is the thing which may happen. So I may go with the same.
Next slide. Next slide. Next slide, please. Next slide. Yes. So this is a Nature paper by Foster et al. And this is not very, it's a commentary to an editor, which has given a detailed research analysis that NASH or an alcoholic liver disease, and they have also mentioned alcoholic liver disease, that NASH or non-hepatitis B or C related CLD limits anti-tumor surveillance in immunotherapy treated HCC. And what they have done is they have documented whatever evidence they have in literature that the amount of Treg cells, the amount of CD4 to CD8 ratio, the amount of inflammation which is required in a tumor and the microenvironment of the tumor is lacking in NASH and alcoholic liver disease as compared to a liver disease, a chronic liver disease, which is hepatitis B or hepatitis C related CLD. So they have just, I mean, you can all go through this paper. They have just said that the atezo or an immunotherapy response, the Himalaya durvalumab or a pembrolizumab response will be higher if they have hypothesized this, will be higher if it is hepatitis B related CLD as compared to a NASH on an alcoholic liver disease. So viral and non-viral etiology related cirrhosis, we do not have a data, but if you see that Dr. Chawla was saying, that if you see that I am brave subset analysis also, the hepatitis B and hepatitis C in the Fortis plot was slightly towards atezo-bev as compared to alcoholic and NASH. So this was a fundamental etiological. When we have three choices, sorafenib, lenvatinib, and atezo, are we wiser enough to choose one of them according to the etiology? There is no data behind it, but this is a concept which Nature has published 1 year back, and there is a research ongoing on this. Dr. Chawla, you agree with this slide or not?
Yeah, no, I fully agree with you. And I wanted to add this point that when sorafenib trial was done, there was not much distinction, and patients who were viral positive, they fared poor as compared to non-viral positive. Subsequent to that,
Yes, sir.
Dr. Ankur, can I chip in just?
Yes, sir, please,
I'm
please.
the gastroenterologist moderator sitting here, Dr. Kingshuk Das from PGI in that way, old days.
Yes, sir.
I'm batchmate of Anjan Dhar. Anjan Dhar was a MAMC fellow ahead of you in that way. He was a gastro batchmate. My question is here. Now, can we buy microRNA? Can differentiate anyway that this is Hep B, Hep C related or the other group, alcohol, NASH related, or you apply more of AI? The time will come one day, maybe another 2 years, 3 years, 4 years down the line. By AI, we'll be able to differentiate this group of people who is going to develop what is CC and what is the etiology there, and getting a direction from there, we'll be able to hit the right place by your either Pembro or
Yes,
whatever
yes,
newer
sir.
things Nemo is coming.
Yes, sir. So yes, you are right, microRNAs and AI related, but a very simple answer to this is get a biopsy done.
Yeah.
Get a biopsy done if your INR, ascites, and there is no contraindication to biopsy. I am actually moving towards biopsy in hepatocellular. Give me a normal INR, give me no ascites. I would go a biopsy. And I was speaking to ILBS fellows, the pathologists there. Get something, tell me that this is an inflamed tumor.
But they say go for a liquid biopsy. Why to do for a biopsy directly? Go for a liquid biopsy and try to substitute that by that.
Sir. So circulating tumor DNA, the circulating RNA, and what is called as TMB, tumor mutational burden.
Yeah.
If you get this, so a liquid biopsy is easy to say, but still a good liquid biopsy platform fetches around 2.7 lakhs, 2.5 lakhs. And just imagine in our OPD setup, when we were struggling to get a lenvatinib dose, we were very happy to get a generic lenvatinib. Forget about, as Dr. Tanuj and Dr. Amit said, atezo-bev is disease and drugs of the richer people. So a liquid biopsy, it has to be standardized. It has to be available. People need to understand this liquid biopsy. And more important, we are sitting with our gastroenterologists, our radiation oncologists, our intervention radiologists, medical oncologists, surgical, hepatologists, hepatic surgeons. They are also parallel department. So the big question is that liver cancer cannot be run by one department. It has to be run by many departments, but all the department has to come on board to decide a liquid biopsy, to decide taste, tear, SBRT. So there are many players in this disease. To get the best outcome, all the players have to talk and discuss this science and implement this science to the patient at a ground level. So
Can I
this is a
say one
big
thing?
thing. Yeah,
Yeah, can I say one thing?
sir.
See, what is the problem with the biopsy earlier was in CLD patients, you are never sure how much it will bleed. So that was the main hesitation about of doing biopsy in a CLD patient with HCC, because HCC is inherently a vascular disease. And
Yes.
that's why the result of TACE are better than any other IV chemotherapy. So now what we do? In some patients, when we are forced, we still don't like to do biopsy because then we are asking for an intervention. Sometimes we have seen so many patients, even with 20 GLP needle, it's bleeds. So what nowadays we are doing is a biopsy system is coaxial. We keep ready with the gel foam paste prepared. What we do is a coaxial system, do the biopsy, it will bleed. We wait for 1 or 2 minutes. If there is significant bleed still coming from the tract, we just embolize with gel foam and come out. So that's what giving a better way of doing biopsy, and we can now go ahead and do biopsy if required.
So I think we are running out of time, and you have raised a very important question. So time is up, but last question to my panelist, whoever wants to answer. What are the re-indications of biopsy in hepatocellular cancer? So Dr. Saha, if you
Only if
can,
you want to give, only if you want to give immunotherapy.
So what I have seen is that the triple washout, the classical radiology, the classical AFP secretors are not always there.
Not
Not always there. Many times that scalloping effect, that when my PET scan or my radiologist clearly says that it looks like a mixed variety. When my CA 19.9 is bit high, alpha fetoprotein is low, I'm suspecting a mixed variety of cholangio and hepatocellular. AFP is not secreting, the patient liver functions are preserved. I want to fetch more out of it. So these are those patients I would like to get a biopsy done, explain the scenario. And many times, how many times you have seen that it was HCC to diagnose with without an alpha fetoprotein secretor, hepatitis B or C or NASH, but it turns out to be a cholangiocarcinoma or a mixed HCC and cholangiocarcinoma. So that changes our scenario. So we have to, as oncology is proceeding further, we have to pick up these patients also. Who will respond or not respond to IO is another question. But a right diagnosis for these patients is also required before actual treatment. Your statement, sir.
Sometime actually, sorry.
Sorry.
Can I just comment one?
Yes, Dr. Banerjee, please, followed by Dr. Saha.
Yeah, there is something known as the bite and burn. So when you feel that this may be a HCC or it may not be HCC, needs a biopsy, but it is a small lesion, maybe a less than 2 centimeter lesion, then it is better to take a biopsy and do a microwave RF at the same setting. This is widely done in Singapore. I was working there in NUH. So this is something known as bite and burn. That is also one point I wanted to comment. Like whenever there is a doubt, but it is a treatable situation, you can combine these two things together.
Thank you, Dr. Saha. Your last comment, please, and then we'll conclude.
This was what I was actually coming to. So he just said that. So this is what we are now doing in some cases. If you need a biopsy, and if there is a small lesion which is treatable, up to 3 to 5 centimeter, we can do a biopsy and do microwave or RF ablation in the same sitting.
Yeah. So at the outside, I will once again thank the chairperson, the organizers, and my panelists. I was just able to finish 25% of what was in my mind, but the time is the big speed breaker in our life. And thank you so much for being so patient and listening to me. And thank you so much again. Yeah.
So, Dr.
Thank you so
Ankur,
much. Thank you, everyone.
Dr. Ankur, can I have a question?
Sure, Dr. Nish.
So I'd like to ask a practical question. So these HCC patients are often cirrhotic and they come up with a splenomegaly and thrombocytopenia. And when considering bevacizumab at a dose of 50 milligram per kg body weight, say patient having early varices, how would you consider proceeding? So do you prefer using a romiplastim kind of stuff, uh, boosting the platelet count, or do you wait? How do you proceed with low platelet count and bevacizumab 15 milligram per kg body weight?
So is this question for me, Dr. Animesh?
Yeah,
Yes.
any medical oncologist.
Yes. So in my practice, first of all, we have to see what is the reason, and most probably it is a chronic liver disease, portal hypertension giving rise to this thrombocytopenia. So my threshold is 80,000, and that was a threshold in I'm Brave. But yes, we have to seriously ligate them, do an endoscopic varicose ligation, treat them, ensure them that they are not bleeding, because the chronic liver disease and upper GI bleeding is common without bevacizumab also, and with bevacizumab, my threshold is 70 to 80,000. If it is less than 70,000, I do not dare to give bevacizumab.
So do you recommend banding for early varices also or advanced varices?
So 40% or 25% of the patient in I Am Brave had upfront esophageal varices, and it is a recommendation before starting bevacizumab, please get an upper GI endoscopy and get them ligated, get them sorted out, because that's an absolute contraindication for Bev. And the I Am Brave 150 also has done that. So 25 to 40% of the patient had an upfront esophageal varices. That should be sorted out first before giving bevacizumab.
Another question, as you have already shown that NCCN guideline 2022. So all the recommendation, I mean, atezolizumab or lenvatinib, are for child puck A. So the sorafenib is probably the only drug apart from nivolumab which are approved for child puck B. So the
Yeah.
case you are mentioning, child puck B7. So what would be your preferred option? Would you go with the recommendation or would you tweak a bit and use the
So
standard?
so in our what I say with double tag is our Indian practice. So I differentiate, and the literature has also differentiated early B and late B. If it is an early B, I go same as A, because we do not get, and our community and the presentation in our OPD does not allow so much of child pug A to come into our OPD. It's always B. What I would say, child pug C is out of question. Child pug A we hardly get, and so I would like to differentiate with this B into an early B and a late B. If it is an early B, I would be happy with lenvatinib, and maybe with some local therapy with SBRT, if it opens up something, patient becomes better, so then maybe atezolizumab. But I've not been using atezolizumab, so sorafenib is a difficult drug. Sorafenib is a theoretical drug left, so I would rather be happy with lenvatinib with good monitoring of hypertension and proteinuria, because these patients have a big component of hepatorenal and other comorbidities.
Dr. Amit or Dr. Tanuj, any comments on this kind of child A, B and selecting the treatment?
So completely agree with Dr. Ankur's comment. So we are taking early, the maximum patient we are getting is of B or C, hardly A we are getting. And for we are treating, they are saying we are treating all the patients. So not C, surely they are the best supportive care group. Might be some patient very keen on treatment, he may give, but it's not the treatment of choice. For B, early B, we are treating surely like this.
Yeah, for me, I would still keep a low threshold for atezolizumab for early B. I'll just see the overall picture of the patient. If he's, generally well young patient, I may try atezolizumab even with early B.
Okay. Thank you. I think we have to conclude the session. Thank you, Dr. Ankur Bahl and all the panelists for joining us today. Thank you, our chairperson. Before we conclude this session, may I request Dr. Naziba to come over and hand over the memento to our chairpersons and panelist, Dr. Mano Shah, sir. Naziba, please. Nazib. Dr. Jibok. So we are at the end of our program. It has been an engaging and wonderful learning experience for me. I think the all of us was joining online or offline today will agree with me. Heartfelt thanks to all the faculties for taking time from their busy schedule and making this program a grand success. I'd like to thank all the delegates joining from different countries for taking their time to attend this program. And I'd like to thank the event management partner, Kavina Creations, Rahul, Kashish, Himangshi, who are working at the back end to over last 2-3 months to make this program successful. Thank to our audiovisual partner, Trade Wings, for helping us with the audiovisual stuff. Uh, Thanks to our trade partner, Roche and Zydus Oncology, for sponsoring us for the CME. And thanks to our local organizing team, our hardworking PGTs, registrar, consultant, for supporting us throughout this preparation. Thanks to our admin, respected DMS sir, CEO sir, medical superintendent sir, and everyone who has been involved in organizing this program. Without all of this support, it might not have been possible. Thank you all. With this, I would conclude this CME. Thank you and good night.